Well, hello there. I'm Chris Starr from the Weill Cornell Medical Center, and with me is my good friend, Marguerite McDonald, and we're going to talk today about one of our favorite topics, and that is dry eyes and assessing tear osmolarity in our dry eye patients. How has tear osmolarity and the TearLab device sort of changed the way you practice, and in particular, how it impacts your preoperative management and pre-op diagnostics?
Well, at last we have a reliable, reproducible metric for dry eye.
Yeah.
And up until now, it's been symptom-driven, which we know is a mistake because half of clinically significant dry eyes, as defined by hyperosmolarity, have no symptoms. It's sort of like saying to a diabetic, "Are you thirsty today? Have a few more units of insulin." I actually have a whole treatment algorithm that's based on the osmolarity score.
As do I. And one of the new paradigms in tear osmolarity is this inter-eye variability, which is now, as we know, is very important. What do you use as your sort of cutoff for inter-eye differences?
8. And homeostasis, I like to explain to the patients and sometimes the residents and fellows who come through our practice that a normal patient has homeostasis around 290 to 295 milliosmoles per liter. If this is my left eye, my right eye, all day long, it's almost exactly the same. And it never changes, even if they have a glass of wine or they take a Claritin or they sit outside at a football game or they go on a long airplane ride. They have enough reserve that they can handle those situations. So with dry eye patients, however, there's wild scatter, wild swinging back and forth in both eyes. And once in a while, even a very dry eye patient will have one eye that dips down almost into the normal range. But it's the inter-eye difference of 8 or greater that really is the hallmark of dry eye, even if they are both within the normal range.
Yeah, it's the instability of the tear film, which is a hallmark. And it's important to note neither eye could be over 308, but if there is that 8 milliosmole per liter difference, that is still dry eyes. Now, if you have a pre-op patient, you're going to do LASIK on PRK, and they have a high osmolarity or an inter-eye difference of 8, what do you do differently as far as managing these patients, if anything?
I delay it for at least a month while I treat them. So if a patient was planning and had even made arrangements with their family to have fairly immediate surgery, and I disappoint them by telling them I'm going to treat them for a month, I have yet to lose someone. They like the fact that I'm being careful.
Yeah, similarly with cataract patients, same thing. If there's a dry eye, if there's an unstable tear film, if there's any corneal staining, it really makes no sense to get Ks, keratometry, topography, especially if you're going to do a premium lens, because those patients, you're going to have errors in calculations. And so do you always get patients optimized in a month, or does it sometimes take longer?
Usually a month is all it takes. Occasionally, somebody will come back and they'll be improved, but not where I want them to be. So, if I put them on, say, Restasis and tears and omega-3s and all the usual things, and they come back in a month and they're improved, but not below 308, then I will put in plugs at that visit. And at the most, it takes about 2 months.
And then post-operatively, we know certainly laser vision correction will exacerbate dryness, and certainly cataract surgery, especially if LRIs are involved, we'll have a relatively neurotrophic cornea afterwards and worsening dry eyes. What do you do post-operatively to manage all of this?
Well, I keep up the pre-op regimen, and that actually worries me a little when you think about it, because suppose this person who has a multifocal, suppose 10, 20 years from now, hopefully we'll have other therapies for dry eye, but what if they stop taking their Restasis and they stop putting drops in because they can't handle the bottles anymore? Their optics will suffer, and they might not enjoy that multifocal like they did the first 10 years. So for as long as we can, as long as they can, we want to keep them on therapy. But maybe coming soon there'll be things that will be perfect for someone who can no longer care that well for themselves.
It's a chronic disease. I think we both agree that in the age of osmolarity measuring, the patients are very engaged with their treatment. They remember their number. They always want to know, what is my number on each visit? They want to see it trending down when they're being treated with Restasis or other things. And so it really has improved compliance. Well, with that, Marguerite, I want to thank you for joining me today.
My pleasure.